This study was an observational cohort study looking at the effect of implementation of universal aspirin prescribing for preeclampsia prevention in a large urban county hospital. We examined before and after what are the rates of preeclampsia in women who had the opportunity to receive aspirin for preeclampsia prevention. This was an observational cohort study looking before and after implementation of universal aspirin in a large urban county hospital population. So in 2022, we implemented universal aspirin to all patients that presented for prenatal care by 16 weeks gestation. Prior to this, we had not routinely recommended aspirin to our patients, even those of moderate or high risk for preeclampsia. That was not part of our practice pattern. And so this was quite a large shift. And we wanted to look retrospectively at those that received aspirin and see if it was associated with an improvement in outcomes. And what we did find is in the cohort of women after we started aspirin universally had a lower risk of severe preeclampsia or preeclampsia with severe features. And we measured that by looking at how many patients received magnesium sulfate during delivery. The finding that really stood out to me the most was how the improvement in outcomes was really across all populations. We looked at patients who had chronic hypertension when entering pregnancy, and we looked at patients who wouldn't qualify for aspirin therapy if you used a risk-based approach. And the benefit of aspirin in decreasing the rate of preeclampsia with severe features was universal across the population. It demonstrated effect in women with hypertension and those who had no risk factors. I think that this study asked a provocative question. If risk-based approach is what serves all populations well, U.S. Preventative Services Task Force and ACOG support universal aspirin use in populations that are predominantly moderate and high risk. And at our institution, the majority of our patients meet at least one moderate to high risk factor. And so we are consistent with ACOG recommendations, but it does beg the question, would it have the same effect in other populations that aren't predominantly moderate and high risk? That's a great question. So I think this is where shared decision making, counseling, and conversations should happen with your patient. We demonstrated benefit even in those who might be considered low risk. And so I think if a patient who is low risk for developing preeclampsia desires to take aspirin in pregnancy, that would be a reasonable choice for them. And so this informs counseling. It doesn't have to change practice, but it definitely informs how you counsel patients. There is quite a bit of evidence that a large number of pregnant patients, especially in the later half of pregnancy, do not demonstrate a full aspirin response with 81 milligrams daily. That, coupled with the largest randomized controlled trial demonstrating benefit of aspirin for preeclampsia prevention, tested 150 milligrams daily, not 81. And so those two pieces of evidence are really what guided our decision to implement 162 milligrams daily. And I think it is an important talking point going forward, looking at our national guidelines. Yes, I would say that the data on whether aspirin is effective in patients with chronic hypertension has been quite mixed. And so I found that to be one of the more interesting things when we were analyzing our data, is that it really did demonstrate benefit across the spectrum. And you're correct. Begs the question, is risk stratification really the direction we want to go? Or is a more wide application possibly going to yield more benefit? While we did find a decrease in postpartum hemorrhage risk, with the group that received aspirin, I would say that in a study with 36,000 patients, a very small difference can be statistically significant, but perhaps not clinically significant. And so what I took away from this is that there certainly was no evidence of increased postpartum hemorrhage in the setting of aspirin. With aspirin, you worry about bleeding. And so I took away that this information, the real number one takeaway was that aspirin demonstrates we demonstrated safety with aspirin in pregnancy. When we looked at the data, like you said, we found that time to diagnosis of preeclampsia was even later in those that did develop preeclampsia with severe features. Overall, we saw very small changes in the rate of preterm birth. We did see a slight decrease in the rate of preterm birth prior to 37 weeks in the cohort that received aspirin. We did not see it at earlier gestational ages. And in fact, when we look at data for extreme preterm birth before 28 weeks, we actually saw a small increase. But when we drill down on that data, and that will be in the manuscript, what we found was that those preterm births in the aspirin cohort less than 28 weeks were not related to preeclampsia. They were related to other causes. And in fact, preterm birth less than 28 weeks for preeclampsia was lower in the aspirin cohort.